We next invite our beloved president, Dr. TVS Gopal, and he is a doyen in regional anesthesia in India as well. And he's one of the first to start ultrasound guided nerve blocks in India. He has an area of expertise in various axes like the arterial axis and orthopedic surgery and the cardiac surgery as well. Dr. Gopal, please.
Thank you for your kind words of introduction, Sandeep. Over the next 20 minutes, I'll be giving you a bird's eye view of lower extremity blocks in modern anesthesia. I must disclose that I have borrowed information from the following sources for the purpose of this lecture. Manoj said this yesterday. As anesthetists, we are all very comfortable performing neuraxial blocks, especially if it comes to lower extremity surgery. There are several advantages, and these include a single injection with either a midline or a paramedian approach. You have bilateral coverage, you have multi-dermal coverage. There is a dense sensory block, especially with a spinal, and both somatic and visceral analgesia are assured. There are inherent problems with performing peripheral blocks of the lower limb. These include the lower limb is innervated by nerves that arise from more than one plexus, which is the lumbar and the sacral plexus. And especially with proximal approaches, these nerves are quite deep-seated, which makes localization of these nerves, either with a PNS or an ultrasound or a combination of both, quite difficult. The American Society of Regional Anesthesia in 2005 published this article to highlight several aspects of lower extremity blockade. This is a modality that was not taught and practiced as often as other forms of regional anesthesia, and it was hoped that this article would spur interests amongst anesthetists. 14 years later, very recently, the second edition of this article was published. And in this intervening period, there has been a resurgence in the practice of lower extremity blocks. And these are the reasons why. As Professor Kessler talked just a while ago, there is an increasing emphasis on anti-thromboembolic prophylaxis. There is the ubiquitous availability of portal ultrasound, and there is also an enhanced focus on early dynamization and discharge to home after lower extremity surgeries. In the intervening period, certain novel anatomical concepts have emerged, like the recognition of the paraneural sheath and the subparaneural compartment. Newer blocks, such as the adductor canal block, have been introduced into practice. There are newer techniques for older blocks, and we also have novel approaches, such as the IPAC or the SPANC, which are motor-sparing blocks to provide analgesia for the posterior capsule following a knee joint arthroscopy or arthroplasty. Today, there is an explosion of newer techniques at the disposal of the modern regional anesthetist, and it is important that we adopt a pragmatic evaluation to identifying how these techniques are useful in practice. And these include efficiency in the perioperative process and patient flow, and increasing access, that is, the ease of integration into existing clinical pathways, decreasing disparities, that is, when we believe that a particular technique is useful, this technique must be offered to patients undergoing this surgery across all hospitals and countries. And finally, there is a focus on improving both short-term as well as long-term outcomes. So let us begin by looking at newer approaches for older blocks. The lumbar plexus, as we know, has been around since 1974, when Winnie spoke about the landmark approach. Then came the loss of resistance by Cheyenne in 1976. Parkinson and colleagues introduced peripheral nerve stimulation in '89, and finally Kirschmeyer introduced ultrasound guidance in 2001. The current gold standard, as we would agree, is a combination of both ultrasound and nerve stimulation. The paramedian transverse oblique scan, which Manoj is so passionate about, tends to identify the shamrock. The stem of the shamrock is the transverse process of the lumbar vertebra, and the three clovers will be constituted by the quadratus lumborum, the erector spinae, and the psoas. The needle is placed at a certain distance from the ultrasound probe, and the needle ventures towards the lumbar plexus in plane with the ultrasound beam, as shown in this particular picture. In 2011, Benston spoke about his approach to the sacral plexus, which is the parasacral parallel shift. He placed the probe, a low-frequency curved probe, towards the midpoint of a line connecting the PSIS and the greater trochanter to identify the continuous line of bone, which is the ilium, and then shifted the probe parallelly towards the sacrum to identify a break in the bone. And this is how the ilium is imaged, and after the parasacral parallel shift, you will see a break in the bone. There is the sacrum, there is the posterior border of the ischium, and then you will see not just the sciatic nerve, but the entire sciatic sacral plexus, which is emerging from underneath the piriformis muscle. Sandeep has published this particular article recently, a series of 50 patients. So you can offer lumbar plexus and sacral plexus blocks to high-risk geriatric patients undergoing hip fracture surgeries. But you must remember that there is a high potential for complications because these are deep-seated blocks, and as Professor Kessler just said, the incidence of bleeding complications is very high with lumbar plexus blocks. So let us look at selective regional analgesia for hip surgery patients. When patients present to the ER with hip surgery, with hip fractures, they are in tremendous pain, and we tend to perform on-arrival blocks in the emergency, and these usually constitute a peripheral nerve block or the fascia iliaca block, the double pop technique, which was introduced by Dalens in 1989. Of late, however, there has been a slight change, and there has been a marked emphasis on ultrasound-guided suprainguinal fascia iliaca block, because it is believed that with this particular technique, you can definitely afford analgesia for both the femoral nerve and the lateral femcutaneous nerve of thigh. The transducer is placed perpendicular to the inguinal crease to identify the sartorius, the internal oblique, and the iliacus muscle. And as shown in this picture, the needle is placed in between the fascia iliaca and the iliacus muscle. This group of anesthetists from Canada recently came up with a newer block for providing analgesia to patients with hip fractures. They called it the pericapsular nerve group, or the PENG. The idea is to block the articular branches of the femoral nerve, the obturator nerve, and when present, the accessory obturator nerve. And these nerves actually innervate the anterior joint capsule. And it's about 60% of pain emanates from the anterior joint capsule. The advantage of this particular block is that there is no palsy of the quadriceps. And as seen in the picture, the two bony landmarks that are identified are the anterior inferior iliac spine and the iliopubic eminence. No lecture these days is complete without a reference to the current block or the current flavor of the season, which is the erector spinae. And there are no surprises to note that both the transmuscular quadratus lumborum block and the erector spinae block have been offered as options for reducing pain in patients coming for hip surgeries. And how about a superior gluteal nerve block? The superior gluteal nerve preferentially innervates the gluteus medius and also the posterolateral capsule of the hip joint. Please concentrate on the knees. The knees are subject to constant wear and tear, and ensuing pathology often necessitates corrective surgery, either arthroscopic or open. We do know that knee joint arthroplasties are offered as a treatment for patients with advanced knee arthritis, and it is becoming increasingly prevalent in aging populations. This is also one of the most painful surgeries to the patient in the immediate postoperative period. Pain emanates from exposed nociceptive nerve endings in the fibrous capsule, the synovium, the peripheral part of meniscus, the intra-articular and extra-articular ligaments of the knee, the infrapatellar pad of fat, and the integument comprising of the subcutaneous tissue and the skin. Less than 2 decades ago, all efforts at post-op analgesia were focused on intrathecal opioids and epidural anesthesia. But then even surgeons started telling us that when you do an epidural for a unilateral knee, you're offering complementary analgesia to the non-operated limb. And then began the era of a femoral block combined with a sciatic nerve block, either single shot or continuous. Then again, questions began to emerge on the validity of a sciatic nerve block, because this is a surgery that involves almost entirely the anterior capsule of the knee joint. And then we started practicing the motor sparing adductor canal block. The adductor canal, triangular in cross section, is an intermuscular canal that extends from the apex of the femoral triangle to the adductor hiatus where it ends. It acts as a conduit for the neurovascular bundle of the thigh to pass through. The exact and specific nature of the nerves that course through the adductor canal was not entirely understood. As per this cadaveric study that was published by this group from Canada, it was seen that in the adductor canal, you do have the nerve to vastus medialis, the saphenous nerve, a deep plexus comprising of branches from the above two nerves, and the anterior obturator nerve definitely goes through the adductor canal. So when you do a knee arthroplasty, the surgeon performs a medial parapatellar arthrotomy. And there is tremendous pain, and this is innervated by nerves that supply the anteromedial aspect of knee. And this includes the saphenous nerve, the anterior femoral cutaneous nerves, the medial retinacular branch of the nerve to vastus medialis, and the anterior obturator nerve. The anterolateral aspect is largely left undisturbed. When there is an intra-articular incision, there is pain from structures that are innervated by the posterior plexus that ramifies around the genicular vasculature in the popliteal fossa. The posterior plexus takes origin principally from the tibial nerve and the posterior obturator nerve. Therefore, if you perform a femoral nerve block or an adductor canal block, you are blocking the innervation towards the anteromedial aspect. And if you perform a selective tibial nerve block or an IPAC or a SPANC, you are providing analgesia to the posterior aspect. In this picture, you see that A corresponds with the apex of the femoral triangle, B corresponds to the midpoint of the adductor canal, and C corresponds to the end of the adductor canal, which is the adductor hiatus. We tend to believe that when we perform an adductor canal block, we select the midpoint of the adductor canal. But if you see this particular study, we tend to believe that the midpoint of the thigh is the halfway mark between the inguinal crease and the popliteal crease. But the textbook definition will tell you that The midpoint of the thigh is indeed the halfway mark between the anterior superior iliac spine and the base of the patella. So if you go by the earlier definition, the midpoint is the blue arrow, and if you go by the latter definition, the midpoint is the red arrow. So if you go by the latter definition, and you perform your block, you're actually performing the block in the femoral triangle and not in the adductor canal. And this has implications as far as post-op analgesia is concerned. So you can actually define the location of the adductor canal using an ultrasound. So in the picture, which is labeled A2, you will see that you are in the femoral triangle and the sartorius muscle is largely lateral to the femoral artery. In the adductor canal, the sartorius muscle overlies the femoral artery, and at the point of the adductor hiatus, you will see that the femoral artery dips down and often gives off the genicular branch. The IPAC was introduced into clinical practice by Sanjay Sinha, who is here, and it is an acronym that stands for infiltration between popliteal artery and capsule of knee. So what we are trying to do is target the genicular nerves, which comprise the posterior plexus, without having the foot drop that accompanies a blockade of the sciatic nerve. So this is Sanjay Sinha performing the block. And you see the medial femoral condyle, you see the popliteal artery. He introduces the needle in this manner in between the condyle and the popliteal artery. And as the needle is withdrawn, about 20 mils of local anesthetic is injected in this particular plane. This was a recent study published by Sanjay Sinha, Vincent Chan, and colleagues. It was a cadaveric study in which the authors compared two approaches to the IPAC. The proximal approach, which was performed supine, and the distal approach, which was performed with the patient or the cadaver in prone position. And with both these approaches, they noted that there was a retrograde spread of local anesthetic from the posterior plexus into the adductor canal. So we can probably conclude that when you perform an IPAC, it somehow strengthens your adductor canal block also. SPANC is a similar block, and it's an acronym that stands for sensory posterior articular nerves of knee. Kerr and Cohan, two orthopedic surgeons from New South Wales in Australia, came up with this concept of high volume local infiltration analgesia. They advocated that 150 mils of 0.2% ropivacaine admixed with ketorolac and epinephrine be injected in 3 aliquots of 50 ml each into the posterior, mediolateral, and anterior compartments. A compression bandage delays systemic absorption, and so there is no real worry of last. But ever since we started performing the IPAC, we don't inject into the posterior compartment anymore. So the surgeons inject only 100 mils, and there are 2 aliquots of 50 ml each. And this is a picture of the surgeon injecting the local anesthetic into the anterior capsule. The paraneural sheath not only functions as a gliding layer, which provides additional protection to the sciatic nerve, but also offers a plane of cleavage, both circumferentially and longitudinally, which acts as a conduit for spread of the local anesthetic solution. Falls in lower extremity surgeries, especially with a lower extremity block, and more so with an indwelling catheter, is a matter of huge concern. It is important to note that most of these falls after orthopedic surgery are due to unassisted mobilization. It is important to prevent these falls by educating our patients, to have fall prevention protocols in place, and ensure that the patient use walkers, crutches, or a wheelchair until after the block has resolved. And finally, in conclusion, The last 14 years have been a golden era for the performance of lower extremity blocks in patients undergoing lower extremity surgeries. Yet, there are certain questions that remain to be answered. It is fondly believed that by the time the third edition of this very informative article is published, solutions will have been found. Thank you for your attention.